Thank you so much, everyone who has joined us today. It is an honor to be here this afternoon. My name is Regine Jackson. I am the president of the Haitian Studies Association, and it is, again, an honor to welcome you to this forum that we have put together in memory of Dr. Paul Farmer, who passed away on February 21st this past year. Dr. Farmer left a big void in the world of public health. He worked with communities and grassroots organizations in Haiti and the Haitian diaspora. He was a fierce advocate for equitable access to healthcare. As a researcher, he highlighted the connections between health disparities and human rights. And as co-founder of the organization Partners in Health, Dr. Farmer was instrumental in building a 300-bed university hospital in the Central Department in Haiti after the 2010 earthquake. We gather today to hold space, to remember Dr. Farmer for his compassion, for his kindness, his relentless advocacy for equitable healthcare around the world, and especially his work in Rwanda and Haiti. We are pleased to have 4 distinguished guests with us today. Dr. Donaldson Conserve, who is a faculty member in the, there we go. One more, there we go. Who is a faculty member, associate professor of prevention and community health at George Washington University. Dr. Toni Eyssallenne, next slide, there we go, who is inaugural director of the intensive care unit for Partners in Health. And also Dr. Pierre Minn, who is, Dr. Pierre Minn, who is associate professor of anthropology and social and preventative medicine at the University of Montreal. We have one panelist who is not here yet. If we can go back one slide, Julio, thank you. Ms. Marc Julmisse, who was the interim director of Zami La Santé, a sister organization of Partners in Health in Haiti. We suspect that there are some technological issues or internet issues that are preventing her from getting here, but as soon as she arrives, she will jump into the conversation. Our 4 panelists will reflect on Dr. Farmer's life, his ideas, his work, and his legacy. And before I turn it over to our moderator for this afternoon, I want to just take a minute to thank the team who worked together to organize this event. HSA board member Laura Wagner, I don't know if Laura's here yet, but thank you. Lynn Selby, who worked on organizing this, helping us to pull this together. HSA secretary, board secretary, Lucien Joseph, who will be our moderator, lovingly known to HSA and the world as Dr. Lou. And finally, Dr. Claudine Michel, who our executive director of the Haitian Studies Association, who it really was responsible for sharing some personal memories about what Paul meant to her that inspired us to sponsor this event. So Julio, I think we can stop sharing the screen, and I want to turn it over to Lucien and to get started with probably a longer introduction of our panelists.
Okay, good afternoon, everyone. Bonjour, bonsoir, ça passe. It's a pleasure to be with our distinguished panelists. We have an amazing team who will reflect on the ideas and works of Dr. Paul Farmer. But before we begin, something we forgot to do, we would like to ask the panelists if it would be okay to record this event so we can share with other people when this event is over.
Yes, that's fine.
Okay, very good. Everyone else, okay?
Yes.
Pierre, is that okay? Very good. Voila. Okay, so first, I mean, we have 5 questions. Well, some of those questions are very specific, some are very general. So any member of the panelists can jump in and answer the question. Then after that, we'll make room, or we'll offer an opportunity to the people in the audience to comment or to ask questions. The bios of the panelists are posted on our website. And let me share, let's see here. So I didn't want to go through their entire bios, and you guys can go there to learn about their work. And since we started a little bit late, it's 4:17. President Regine Jackson already did an excellent job introducing our panelists. So, any questions before we begin? Okay, so let's do it. The first question, can you please share with the people in the audience about your personal experience in working with Dr. Paul Farmer? For example, what have you learned from him? Anybody can jump in and answer that question.
Well, I'll take this one to start, since I'm the only one not muted. Hello, everyone. My name is Donaldson Conserve, as you see on the screen, and I'm an associate professor at GW. My work focuses on HIV prevention and treatment using community-based models, and I start with this because this is really the angle that I use to start learning about Paul Farmer's work, and to continue working in this area and benefiting from the work that Paul Farmer has done to promote for the advocacy of HIV treatment. So personally, I began working with Zamila Santé in 2010 after the earthquake, when I was looking for an opportunity to go to Haiti. As many of you can understand, during that time, there were several needs, and people all over the world wanted to help. So I wanted to help. I was a first-year PhD student at the time at Penn State University in the biobehavioral health department. I was looking everywhere with the understanding that it would be difficult, but thankfully, someone from Zamila Santé, whom I met at Yale University at a conference on global mental health, decided to connect me with the team in Haiti, particularly Pastor Edzi. He was the director of the psychosocial and mental health team at the time. And shortly after the connection, the team responded, agreeing for me to come to Haiti and interning with the psychosocial and mental health team, learning both about the work that they had been doing for the HIV work related to social and mental health support for kids who had been orphaned by HIV and were maybe being cared for by their by uncles or family members. So, as well as the mental health work that the team was getting started for the people who had survived the earthquake. So that is how I became affiliated with Zamila Santé, and eventually focusing on the work that they have been doing on HIV more specifically. And what this work taught me was that it is immense during the time I spent in Haiti to be able to observe instead of just reading about the work that was going on in Haiti, but to see the kind of coordination and the size of the team and just the drive of the people. And as a PhD student at that time, I was very inspired, and especially when I had a chance to meet Paul Farmer during that internship briefly, even though it was not necessarily working with him directly, but it was working with his, the team that he had really been leading for a long time. So that is a little bit of my experience, and I'll share a little bit more after. But I think, as we all can imagine, it takes a lot of work, whether we're working in public health or whether we're working in any kind of field. And the impact I believe Paul Farmer has had on people, not just in the medical field, I think it's really immense. And as much as it is sad that he has passed suddenly, one of the things that comfort me throughout this difficult time is knowing that the work that he had started many years ago has left such an impact on so many people, has saved so many people's lives, and will continue because of the many people that have joined the effort that he has started with other colleagues and believe in the cause that he lived for. So I'll stop there for now and pass it on to the other panelists.
Thank you so much, Dr. Conserve.
I can go ahead and go next. My name is Toni Eyssallenne. I'm super excited to be here. Thank you again for the invitation. So my experience with Dr. Farmer, I was actually introduced to him through my first mentor in my work in Haiti, Rosemarie Carici, who is one of the founders of Hope, another nonprofit in the north side of Haiti and Born. And my first trip to Haiti, when I was talking to Rosemarie, she's the one who told me about Dr. Farmer, and she was actually one of the mentors for his book, AIDS and Accusations. And so she told me about him and I was like, who is this guy? And I was in medical school at the time. And I was like, a non-Haitian, like dedicating himself to Haiti. I was like, I need to learn about this a little bit more. I was starting my journey into understanding Haiti. I'm also Haitian American, and I have been passionate. My parents fled Haiti because of the Duvalier era, and I've always been interested in trying to understand that, and always growing up, anybody who's Haitian American who lived in that time frame, the conversation in the home was always, we're going home. Once this guy gets out of here, we're going home, and so we were always waiting to see what we could do to go home. So I was very involved in understanding the history and the politics. So when I went to medical school, my dream was to be a physician in Haiti. And so I started that with Rosemarie. She introduced me to Dr. Farmer. He came to the University of Rochester, which is where I trained to get my MD and my PhD. And he gave a couple of talks, and that's when I met him, and she was very close to him. So she actually had hosted him in her home. And I saw one of the first times I saw his fire was when he had a very passionate conversation with another member of the Haitian community, and they were going toe to toe with politics. And I was like, my God, I feel like I'm in my family's house, like the way that they were going back and forth. And he was really passionate. And anybody who knows him knows that he was an incredibly passionate human being about what the right thing to do about Haiti is, and how to get to the root causes of all of the issues. And so after that, I continued to work with Hope, and was able to, through him, get some exposure to Partners in Health in Bel Air, actually. And I spent more time with the group, with Zomi La Santé. I got to go to Cange, got to see what he was doing in Cange. And then after the earthquake, kind of just had a peripheral involvement and saw him when he gave talks. And because of the Rosemarie connection, he always remembered me. When I got to my residency, and I was finishing my residency in 2010 in Miami, he's actually, I'm going to back up. He's actually the reason why we had a global health program in Miami, because he was actually repeating what he had created in Harvard. He was supporting some philanthropists who were trying to do the same thing in Miami. And I was able to get involved in that program so that I can continue my work in Haiti and not have to take away from my education as a resident. And so I met him there again, definitely took a couple of classes in global health delivery that he taught. And so there's always just been this student mentor connection with Dr. Farmer. He always made me feel like he remembered every nitty gritty detail about me, which I was always like, I'm a nobody. What are you doing? It's, like, why are you paying so much attention to me? And I remember one of our times in Haiti, this was before not in Haiti, in Miami, this was before the earthquake. There's an organization called the Haitian American Physicians Association, which I got involved with. And he was a frequent member or participant in that organization, their conferences. And he had been offered being, I think, a UN envoy to Haiti at the time. He was considering it. And I remember going up to him and being like, really? Are you really you're gonna do that job? And he turned to me, looked me dead in the eye, and he was like, should I not take it? And I was like, does he really care what I think? Like he turned to me like, oh my God, Toni, should I not take it? Like I was really a confidant. And I was like, this guy's really, really an incredible human being, right? Like he's making me feel, from what I know from the books that I've read, he's always been so critical of these institutions. And now you're going to be one of them, and he was very conflicted, and he didn't mind telling me that and sharing that with me, After the earthquake, I joined Project MediShare. I was in Miami, so Project MediShare was in Miami, and they helped me through the Haitian Physicians Association, helped me get to Haiti. So I was on the ground 2 days after the earthquake. And worked for the month in the tent hospitals and all of that stuff that happened there. PIH had still been working on the border at that time, so I didn't really get to connect with him at that point. But after I finished my residency, after the month that I spent after the earthquake, I had to go back to finish my residency, and then I completed the program that he helped to start in Miami. What I had negotiated was to basically not do my MPH because I already have a PhD. I was like, I don't need another degree. I was like, if I could like live out the rest of this program, just staying in Haiti and actually helping Project MediShare, because at the time they were having weekly chief medical officers, and I said that's not good. these were all foreigners and volunteers, and I was like, that's not good. So I basically said, I'll forfeit the MPH, just let me be, the person to organize the volunteers and organize the medical care that is happening from the volunteer perspective, and make sure that Haitians are not getting hurt, by bad protocols and all of those things, and folks that don't understand Haiti. During that time, I was able to help build their intensive care unit, and their intensive care unit in pediatrics and in medicine, their spinal cord unit, and they had started building Mirebalais about maybe two years into that process. So I basically lived in Haiti after that for several years. And during that process, I think it was in 2014, PIH approached me to help build their intensive care unit in Mirebalais. They had already started the hospital. I had been there when they had inaugurated the hospital and seeing all the work that Dr. Farmer had done to build this place. I was just so like amazed, right, that he was able to just will this university into existence in the middle of, Mirebalais, Haiti, right? I mean, he just brought so much life to a place that so many people would consider lifeless, and it was just such an amazing thing to do. And so after that, I joined Mirebalais, and I worked in building their intensive care unit, and interacted with him because I was building the intensive care unit, and he always came and checked on patients. Everybody has a story about walking to a patient's home with Dr. Farmer that he was visiting to see how they were doing. And so I was able to participate in that. And I think that, what I've learned from him in all of this time has been that, he was a relentless advocate. I mean, if you want to learn how to be a relentless advocate, that it's basically him. He doesn't take no for an answer at any juncture. And so that has been what has inspired me, especially as somebody who's not blood related to Haiti, but my God, the spirit and the heart that he has for the country. How could I not be involved? And so he kept me honest in my work. And so I'm gonna go ahead and turn that over to Pierre.
Thanks, Toni. And thank you so much to the Haitian Studies Association for this invitation. And even though it's been a few months, I'd like to extend my condolences to anybody who's close to Dr. Farmer and who has suffered his departure as a personal loss. And I think even those of us who, I did not have a close personal relationship with him, but his death was a huge blow. I think really marked something very tragic and very sad, given how young he was, how involved he was in shaping the lives of others. And I think we can all agree that his death, his premature death, is such a huge loss for so many people. And so I think in this celebration of life, we also have to acknowledge this loss, that his departure was so early. So I have in some ways, a kind of a parallel story to Toni, who I also met Dr. Farmer through Rosemary Kirichi, and I'm going to go ahead and post her obituary in the chat, because one of the things that I've become interested in is how certain people emerge as global health heroes and how others don't necessarily. So for many of you, this may be the first time that you hear about this extraordinary woman who, as Toni mentioned, was a mentor to Dr. Farmer, was on the advisory board of PIH when it was founded, and has been involved in bringing healthcare and economic justice to people in northern Haiti for now almost 30 years, and who passed away. Dr. Kirichi unfortunately passed away in 2020. And so we miss her a lot. But she introduced me to Dr. Farmer, who I had the pleasure of meeting at a couple of talks, and similar to Toni, before she knew him well, was amazed by, he remembered me, he remembered my face, he remembered that I was a student in anthropology, and then I had spent time in rural Haiti with Rosemary. And Dr. Farmer, in the mid late 90s, when I started working in Haiti, PIH had just gone through a fairly rough period. The early 90s were very difficult for the organization. The coup from 91 to 94 did a lot of damage to the organization and to people that PIH and Dr. Farmer cared about. And so in the late 90s, they were starting to gain a little bit of visibility. I believe it was in those years that HSA gave Dr. Farmer a prestigious award. I met him at St. Michael's College. I think that was 2001 or 2002 in those years. And as I started my master's and eventually my PhD in anthropology, I was reading more and more of his work. So AIDS and Accusation, but also Infections and Inequality, Pathologies of Power. He really liked alliteration in his titles. The Uses of Haiti, which is really about the relationship between Haiti and the United States. And what I think Dr. Farmer did so well, and his earliest work was really on very local folk medical conditions in Haiti. Some of you remember a work on spoiled milk, lait gâté, and mauvais sang, bad blood, which he researched in the late 80s, mid and late 80s, in the Central Plateau as kind of folk illness syndromes, which was a popular topic in medical anthropology at that period. It was kind of comparing how people talk about their health and diseases in ways that don't correspond to biomedicine or biomedical categories. But what he went on to do, which had such a big impact, I think, on how many of us see health, was to link these individual stories of pathologies, the woman who had gone to work as a maid in Port-au-Prince, or the man who had criticized the Haitian government when he was riding in the back of a truck just by complaining about the quality of the roads, and connecting those individual stories and individual pathologies to macro forces. So the Pelik Dam that was built after having been planned in the United States, the US intervention from 1915 to 1934 and subsequent interventions, French colonialism in the 17th century, 18th century, and essentially European and American presence in Haiti and Haiti's implication in capitalist systems and in world systems, how these macro forces had impacts on the lives of ordinary people in rural Haiti, and making those intellectual leaps through a political economy of health lens from the macro to the micro and connecting them really was going against a lot of trends, both in social sciences and medicine, which focused on individual beliefs, individual behaviors. We know, of course, with HIV/AIDS, blame around behavior, stigmatized identities, etc. And Dr. Farmer was so aware of the damage and racism associated, particularly with the stigmatization of Haitians around HIV, and wanted to connect individual pathologies and that sickness there to macro forces and what was going on in the global system. So I went on to do my PhD, doing fieldwork in Haiti, on international medical aid. And we can say that, projects like Dr. Farmer's and Rosemary's and all of the other people who are doing international work in Haiti, one of the things oftentimes that I felt was missing from their analyses was, what about the middle layer? So we learned a lot about the patients. We learned a lot about the powerful countries and policies that shape healthcare around the world. But I noticed that in a lot of these texts, we didn't hear much about Haitian doctors and nurses who are frontline workers and who occupy this in-between space as intermediaries between international aid and patients, who in Haitian public hospitals tend to be folks who are impoverished, either rural peasants or members of the lower classes in cities involved in small-scale commerce. And so that's what I went on to study in a way that I hoped would be complementary to some of Dr. Farmer's research, was to look at this middle layer of, okay, we've made a good case for global health. We've made a good case that HIV treatments are feasible and important and possible and a moral obligation in Haiti. Now, when we get those up and running, what does that look like? How do Haitian doctors and nurses on an everyday basis negotiate between the pressures of their patients who need care so badly, and oftentimes the resources aren't enough, and the donors, whether they be governments or large NGOs or other forces that are trying to get different forms of resources into Haiti. And we know there's a big critique of the NGO sector. We know there's a big critique of international interventions. We know that they are very diverse, not homogenous. So I went on to look at groups that resembled PIH in that they were mostly secular, that they cooperated with the Haitian public system, and that they relied on Haitian doctors and nurses to look at this class of intermediary folks who are stuck between, in a sense, a rock and a hard place between the patients and between the wealthy donors. So Dr. Farmer's work continues to influence my thinking. I continue to use his writings when I teach. And I continue to also encourage us in how do we make his legacy and his work stay alive in different ways. And part of that, and I've had conversations with Toni about this, also involves how do we decolonize global health? How do we move away from white savior models, which I think Dr. Farmer rejected, but at the same time is oftentimes presented as a kind of savior of Haiti, as a white man from the United States affiliated with a powerful university. How do we call into question these legacies, and how do we really transform healthcare so that it's not about just charity or working through guilt or working through powerful structures, but calling them into question and creating more radical approaches to global health.
Wow, wonderful. Thank you so much for sharing your wonderful stories and personal experiences with us, right? About your connections with Dr. Paul Farmer. Is Marc Julmisse in the room? I would like to give her an opportunity to respond to the question. Okay, not yet. Very good. So, well, let's move to the second question. Some of you have already answered that question, but I'm going to ask it anyway, just in case you want to elaborate a little bit. The second question, how has Dr. Farmer's activism for global health equity and practice inspired your own work, or even your own scholarship ideas, or as a scholar, a practitioner? Anyone can? Okay.
I'll share my story a little bit more, especially in the lens of HIV prevention and treatment. Earlier on, I think as I was reflecting on Paul Farmer's work, I realized perhaps what drove him to not just work in Haiti, but also in so many other countries like Rwanda, Liberia, and Latin America, is what may have also driven me to expand my work from Haiti to East Africa and Tanzania, South Africa, Nigeria, and other places, is that in all of these different settings, there are so many similarities that drive people who see how they could potentially contribute to the health as well as to the social resources that these different communities may need. So, for example, when I was in South Africa doing an internship in a township called Masifumelele, this was for me when I became aware that research or global health or whatever field that in terms that we use to refer to what we are doing in these communities is not just about the impact of the work in maybe in Haiti or in the United States, is that all of these different evidence from these different places can be used to inform what happens in these different settings. And I think based on what Paul Farmer has done in these different spaces, the model that started being developed in Haiti, he was able to take and implement or adapt it in Rwanda or Liberia, in so many of these places, shows the similarities that travel across borders. And for me, when I work in these different communities, I use the lens of thinking that, yes, I'm here for the work, but also beyond the work that I'm doing, what are the other impact or what are the other ways I can interact with this community? So for example, I remember when I first went to Tanzania in Dar es Salaam for a project focusing on community-based HIV testing and treatment, I would go into the community, and the more time I spent walking around and watching the kids run around, watching adults go about their business or playing different games, I began to think beyond HIV and thinking more of the fact that these are people who are not being, who are not waking up thinking about HIV. They are dealing with everything that everyone else is dealing with. How do we put food on our tables? How do we, send our kids to school? And I think having spent time in Haiti, with Zami La Santé, really showed me that you have to go beyond, the disease that you're maybe an expert in. And when you interact with the kids, you cannot use a lens of just medical doctor. You have to see beyond the topic of work and see people as human beings. And I think that's one aspect of Paul Farmer's work that really came across, not just to the community members that he worked for and with, but even the staff like Toni and Pierre. I mean, not Pierre, you're not working for something like that, but I believe the impact he has had on how he interacts with people is what really I think I've taken with me in all of these different spaces that I work, and thinking about how do you make somebody feel. I mean, Paul Farmer, as Toni and Pierre mentioned, I feel it's like when I met him, he talked to me as if he had known me for so long. And it's really just based, I guess, the information that was shared with the team, and he remembered me. And I said, "Oh, you know that I'm here?" He's like, "Yes. Depuis longtemps, you know, même que this and that." I'm like, I was taken aback because again, I was just an intern, and I think that the way we treat people, and I know this is one of the questions that's coming up, but I think it's really how do we make every person feel like a human being, right? This is really, I feel like, what Paul Farmer set out to do in global health. And in HIV specifically, I wanted to share that early on in the pandemic or in the epidemic of HIV, the treatment were only available for people who could afford it. And the model was that, especially for Haiti or other resource-constrained places, that providing these very expensive drugs to people who cannot afford them may not be sustainable because there's, thinking about the profit that needs to be made from these drugs. And Paul Farmer advocated for these drugs to be provided for free. And eventually, in 2004, the law and policy started to change to provide HIV treatment globally for free. So as I think about the work that I do for HIV testing, till this day, people are being able to receive these treatment wherever the need may be. And I think going from Haiti to Rwanda or to all these different places, there is the impact that global health researchers, scholars has. And when people read, I mean, it's one thing to be trained as a scholar and read the typical literature that talks about diseases or the way that people believe in the Western world. But I think when you are exposed to the kind of work that Dr. Paul Farmer has done and so many other individuals who use a different lens, it definitely opens up a different way of thinking. And you can have whoever is exposed to that kind of work can have a different impact in whatever communities that they work for. So that's what I have taken from the kind of work that Dr. Paul Farmer has done by going into the communities and not just thinking about disease, but people and putting those aspects first. So thank you, Toni, if you don't mind, or Pierre.
Thank you. Thank you, Dr. Conserve.
Yeah, I mean, I think the fact that he worked in so many different areas doing the same stuff is very telling about what is the heart of inequity, right? And I think that he basically was able to demonstrate, loud and proud that a lot of these disparities are deeply steeped in colonialism and deeply steeped in capitalism and deeply steeped in racism. And that, if we can do it in Haiti, you can do it everywhere, right? And that I think is incredibly profound and actually shapes everything that you do. Being back in the United States, I worked for a very long time in Haiti. Never really planned to come back to the US, but circumstances changed and I came back into the US and understanding US health disparities. I mean, I understand it deeply because I understand disparities from the Haitian perspective. And it's not different. It's not different. It's the same story. It's just a different landscape, right? And so if you see the disparities that happen in the US and you compare it to the disparities in Haiti, for example, there's just so much. It's a shocking and heartbreaking story in terms of how similar they are, right? And the fact that the fact that you had Hurricane Katrina and the fact that you had all the deaths that occurred there, right? And then the fact that you can have a tropical storm like Tropical Storm Laura, and we lost people. I lost one of the residents that I was training in my residency program, swept away in the year of 2020, swept away. And these issues, I think his work is that whatever you can do in a place where everybody says it's impossible, you can do it if you take out all of the obstacles and the barriers for that, and you can basically uplift and demonstrate to everyone what's really going on. And what's really going on is that marginalized folks, historically marginalized folks, they're just not at the front and center, and the system is designed to keep them down. And that's what he was fighting. And those are that's what he demonstrated to the world. And what's so powerful about what he did, I mean, I think the HIV story that Donaldson was talking about is incredibly nothing less than extraordinary, because by doing that for Haiti, it changed the world. It changed what the access to HIV medications for the world. Right. And I think that is such a big lesson that he taught, is that, like, if you can do it one place, you can do it everywhere. And if you're not doing it everywhere, it's because you're choosing to not do it everywhere. And he forced us to look at those realities. Pierre?
Yeah, I think one thing that there's so much there. The stakes of the work in global health are so high. The scale, the scope of the problem, when you take these macro views, looking at world history, looking at capitalism, looking at like kind of the big issues of how the world runs, it's exhausting. And then it's also exhausting to build relationships with individuals and remember their names and their faces and stay connected and progress with them. And I think this is one of the things that so many people were impressed by Dr. Farmer's capacity to do, was to span both individual patients, their charts, their trajectories, their kids' first communion, their viral load, and then be looking at policy on a global level and be thinking about communities and populations. And I think, you get a sense from his work and his writing that this was not easy for him, even though he made it look easy because he was such a good writer and he was such a charismatic speaker. I think it's something really that tormented him. And if you've read Mountain Beyond Mountains, you'll remember this quote where Tracy Kidder, the author of the biography of Paul Farmer and Mountain Beyond Mountains, asks him about, like, why are you doing this, or why so much, or can't you just stop or take a break or rest? And you hear him say, if I do not work this hard, somebody dies. Every moment where I am not providing care or advocacy or bringing meds down from Boston, people are going to die. And he says, I feel the weight of that constantly. And so, he had a great sense of humor, between the jokes, between the, kind of the exuberant personality. I think you had somebody who was so distressed by the state of the world. And that distress was much of what pushed him to do something wrong, this injustice and this anger. And one of the things that I hope to keep from Dr. Farmer, but it's difficult, is that we have to be angry and we have to be heartbroken and we have to be sad, because the world is not how it should be. And Haiti, of all places, shows that. And, it's kind of it's this always back and forth where I want to have good feelings about Haiti and Haitian people and what happens there. And every time I take a trip, I try to do something fun. I try to see my friends. Toni and I got to travel together to these amazing sites. I remember trips with Lynn, who's on this Zoom as well, of, going to different protests or going to different music nights to keep that kind of affection alive. But the truth is that, the situation in Haiti and what's happening there is heartbreaking. It is infuriating. And we have to know how to live with that and have it fuel action, not cynicism or passivity. And it's very hard. It's very hard. It's exhausting. It's painful. It's heartbreaking. And for someone who has no roots in Haiti, no family ties to Haiti, in a way, it's easier for me, because I could say, well, I will, I'll go work in Guatemala. I'll go work in Tahiti. My dad always misunderstood where I work. And it was like, well, when do you go back to Tahiti? I'm like, I'm not working in Tahiti. I'm working in Haiti. But, for those folks from who have, who are Haitian American, other members of Haitian diasporas elsewhere, there is, I think, difficult decisions to make about engagement for change, about how, folks are going to feel. And with a lot of the physicians that I worked with, the decision to leave the country, to stay. Someone asked a question about Dr. Farmer's involvement in training of Haitian doctors in Haiti and overseas, encouraging Haitian doctors to work in the countryside. Suchet Louis posed this question. I will just say that, it's interesting to track when Dr. Farmer began working in Haiti in the 1980s. Most Haitian physicians historically had been from the country's urban upper class. So the medical school in Port-au-Prince attracted people from families who were relatively well-to-do, and who had access to political power, to education, and certain levels of social class. Maybe not everybody, but essentially from families who were part of Haiti's more powerful elite. This is no longer the case today. And so how we think about Haitian physicians, because elite families in Haiti today, they may send their children to high school in Haiti, but not to universities. So when I was interviewing young Haitian physicians, many of whom now are working in Mirebalais or connected to it, and I asked them what their parents did. The parents were not doctors and nurses, very few of them. The parents were market women, elementary school teachers, working as government officials at low levels, usually in the region. And the majority of the folks I worked with, physicians, were not from Port-au-Prince. They were from outside the country. So it's interesting. Many of them are less interested in working in Port-au-Prince today because they may not have family roots there. They may be concerned about insecurity, which recently has been targeting Haitian medical professionals in ways that are so violent and terrible. I mean, targeting anybody is horrible, but for those of us who have an investment in healthcare, knowing that the doctor or the nurse is terrified to just give care to their patients or to go out, or for teachers or anybody doing this kind of public service, we know what the impact is, when Haitian hospitals close down because their doctors are afraid to go to work. And this is something that Dr. Farmer, I think, wrestled with. And a final anecdote that I heard, I don't know if this is apocryphal, I have to ask around and hear if maybe it's true. Why the hospital at Mirebalais? When Partners in Health had been so focused on frontline care that generally involved small dispensaries and clinics, and doing kind of comprehensive health care that could involve vaccinations, family planning, reproductive health care, work on nutrition, infectious disease control, many of which can be done by Agents Santé, with their famous kind of accompagnement model that PIH really has promoted. Why, kind of this big hospital in Mirebalais, in part, and again, I'm repeating something that someone told me, it was to kind of tell the Port-au-Prince elite, we don't need your city, we don't need your capital, we can do it outside. You guys have not wanted to work out here in this region, the poorest region of Haiti, the Plateau Central. We're going to do it out here, and we're going to show that it is possible. So there was a conversation, and there always is a conversation between foreigners, the Haitian elite, foreign medical professionals. There's some beautiful collaborations. There's also accusations and tensions. And some of the work that I've been doing has looked at the different categories, not just around white saviors or kind of international heroes, but also how Haitian doctors, Haitian professionals, and the Haitian elite are sometimes seen as the most repugnant elite. I know we've all heard this expression, the MREs, how they are accused of corruption, whether or not that's founded in empirical fact, but the assumption is that there's corruption where there's power in Haiti. Or that they are viewed as local champions and that they are viewed as self-sacrificing heroes. So looking at how Haitian doctors and nurses negotiate, this space between being seen as elite parasites or as, corrupt people who benefit off the poverty of their country, or as heroes, those who stayed, those who sacrificed, etc. Very different type of categories than those who were applied to folks like Dr. Farmer. And the word that was generally used to describe Paul Farmer was a saint. And that's a really interesting term in what it implies around otherness, around separation from society, around self-renunciation, and for international medical heroes, a lot of times a confrontation with danger, the idea that when foreigners go to Haiti, they are in danger, they're putting themselves in danger. Oftentimes that erases the everyday danger that everybody in Haiti faces, especially today with the climate of insecurity, that it's not safe, particularly in the Port-au-Prince area, just to go about one's business. So how we evaluate what's dangerous for whom, I think, needs to always be part of a bigger reflection.
Very good. Is there anyone else who would like to comment on how Dr. Farmer's involvement in training of Haitian doctors in Haiti and overseas? Anyone else want?
Celestia, I don't want to interrupt, but Marc Julmisse is here, so maybe let's introduce her and invite her to speak.
Sure. Hello, Marc Julmisse. Bonsoir. Welcome.
Bonsoir. Welcome. Thank you. I'm so sorry. I had some connection issues.
Very good. Very good. Well, we posted the questions in the chat room. We are currently discussing question number 2. How has Dr. Farmer's activism for global health equity and practice inspired your own work or your own practice, as a doctor, nurse, or a scholar? So if you would like to comment, that would be great, greatly appreciated. So.
Thank you. Thank you. And it's so great to see everyone. I will actually tell you, right now I am I've worked for PIH since 2013 when we opened the Mirebalais Hospital. Been in Haiti since 2010, but joined this organization. And I honestly, in the first meeting that I had with Paul, I have, from having read about him, I can tell you there was 3 organizations that when I finished my master's in global health that I said I wanted to work with, and Partners in Health was one of them, because of the impact and the long-term impact. It was an organization that did not really look at just short-term interventions, but really looked at what's that long-term systemic change that could be made. And honestly, during my first encounter with him, if I did not drink the Kool-Aid then, I said I was bathed in the Kool-Aid at that point. It was so genuine. It wasn't just about this. Sorry. It wasn't just about this one founder that did something, was hands off. It was about this system of change that started this movement that really he started. And in the Mirebalais Hospital, and I did catch some of what you were saying, the previous speaker was saying, and one of the things in the Mirebalais Hospital was also saying that when we did it, it was showing what was possible, and continuing putting, because one of the things he consistently said, or that PIH really talks about, is the fact that, this is, we do whatever it takes. And this is, healthcare is a right for everyone. There's no category or person that has a scale or this gradient of quality of care that can be provided. And I will tell you that message really drove home to me and really had a paradigm shift for me a little bit more in when we had the conjoined twin separation. And I can tell you that was several years into working and still thinking that I believed in the mission. But that paradigm shift happened when I remember at one point when we were having our discussion and we had just opened, Dr. Eyssallenne is there, we had opened our ICU and we did not have a pediatric ICU yet. And we just started training our staff in pediatric intensive care. And I was like, I don't think we can. I said, we don't have this and we don't have that and we don't have this. And I was looking at all the obstacles that we didn't have. And I remember when he did say to me, he turned around and sort of looked at me with this really intense look. And it's just almost like trying to get me to get the mission in there. He said, Marc, don't tell me what we don't have. Tell me what we need. And at that point, because I was looking at where we don't have the training, we don't have the material, we don't have this. And it was like, wait, let's stop right here. Yes, this is, if we look at what we don't have and we saying in a country such as Haiti, and I think that's sort of where my mindset was at that point, then we're still going to stay where we are and we're not going to push that barrier, not saying that we don't deserve or we cannot have that same access to care or that quality of care. We can do but so much and no more. And at that point, it really pushed me, and everything else I've done from that point on was saying like, okay, if we're going to get this, what do we need? And how do we get there? What are these steps? And be very logical, not saying like this pie in the sky and saying, we are going to do this, but not be logical about this and not be clear. But what really happened for me, and the reason I'm still here, is every day when we talk about patients, and when he came to Haiti and he would literally do patient rounds, and I would follow with him when I'd have the chance to join him in patient rounds. It was about the quality, it was about the access, but it was also about the personal touch. That one thing that we talked about, those 5 S's that we talk about: staff, stuff, space, systems, and social support for our patients. So it wasn't just about putting all this clinical in, but he's like, hey, did that patient eat? After the earthquake, when we went down, when Paul came down, and I do remember we had several patients that were transferred over to our facility. And one patient had, during the earthquake in the South, this is the earthquake that happened in August 2021, with everything and the flying patients over, one of the things, a patient lost their cell phone during the earthquake and had no way to contact family member. And as we're providing care for all this, the question started being, for that social support, can we get this patient a cell phone? We need to make sure that they have communication with their family. So I'm still here because when we talk about equity, we talk about justice. When we talk about providing care, it's with the patient at the center. And that's what he believed. And that's what holds me here. And that's really what changed how I see the care that we provide, is that patient's at the center. That's the goal. And everything else we want to do to provide care for that patient, whether we have these obstacles, tell us, how do we get past those obstacles and what steps do we need to make? And then let's move towards there instead of looking at just the barriers. I hope that answered the question.
Very good. Wow. You see, I'm taking my notes so far. 2 pages of notes. Okay, thank you so much. Okay. Any more comments before we explore the 3rd question?
There is a question in the chat. Perhaps we could
okay,
it as well, if possible, about Dr. Palmer's work and whether it will be sustainable, and how is his approach different than that of many NGOs working in health in Haiti. So I'll put it out there, and perhaps let everyone, Mark, if you wanted to take that one as well, since you just joined us and are fresh.
Yeah, I can just go back to thank you so much. I think we can go back to what we talk about, those, and that is not just like a campaign slogan for us when we talk about, and it's constantly, every time we say, are we covering the staff, the 5 S's, are we covering the staff? Do we have the appropriate staff, the appropriate training, the appropriate amount that we need to do the work? Do we have the stuff that we need, the materials? That shouldn't be one of our obstacles. When can we get it? How do we get it? How do we make sure that we consistently have it? Who do we contact for this one? Do we have those systems in place? Because one thing that he did say, if you look at some of the things that he wrote, and even when he talked about Paul, or overall, what we've done is, the reason that a lot of things, or the reason that you have certain health outcomes, negative outcomes, is because of systems that are not in place. And so as we're working about direct patient care and the stuff, do we have those systems? Do you have the supply chain system? Do you have the transport system? Do you have the communication system? Are you in contact? Are we having the advocacy part of it with the Ministry of Health, with the governments, with the various areas? So staff, space, systems, and social support is one of the things that we're talking about. Space, is that and this is going back to the L'Hôpital Mirebalais and also the other facilities that we support in Haiti. Are those facilities up to the level that they need to be in order to provide the care that we should be caring for? And also, as we're opening another area, we have to think about, is that space sufficient? Where do we need to put like, for instance, we need a better oncology space. So we're thinking about, where is it? Is that flow correctly? Can the patients get to it easy? And in that one thing, social support in all that we're doing. And I think that's one of the big differences is, again, we, in providing some of the services, we looked at data as far as the distance from where patients are coming from. What support do we need to give them financially to get there if we're able to? What support nutrition wise? Because if you looked at where we started, PH started, was looking at with TB HIV, one of the things was actually looking at the accompaniment model, is really looking at what's going on at home. Do they have the nutrition that they need? Do they have the support they need to be able to take the medication? And so I think the big difference that we have as far as within PIH that we're looking at is we're really looking at putting that systems first. Putting patient support, social support as one of the key drivers. And the other part is really tied to patient support, is really looking at the whole accompaniment model. And I'll stop right there. I don't know if anybody else has.
Yeah, I want to add about the approach different from the other NGOs. I looked at this a lot being in Haiti. As you know, that sometimes the nickname for Haiti is the Republic of NGOs, which really irritated me, to be honest. And because it's not like Haiti's in a better situation. And a lot of these NGOs are actually benefiting from the poverty that Haiti is experiencing and the tragedies, right? They're benefiting from it. And I think one of the things that I really appreciated about Dr. Farmer's approach, Rosemary Caricci's approach, was it wasn't about them. They would be happy to work themselves out of a job. Like, that would be awesome. It was about how do we get the community engaged in and implicated in what is going on in the community. So it's not about, when I was teaching about global health to students and building these global health programs, it's like, why are you going? What's your why? What's the reason? Because if it's to stamp a passport, don't come here. It would literally be like, what is the reason? And a lot of these NGOs are there because they want to stamp passports. They want to tell people what they're doing. They want to be there for a week. They want to go to the beach. They want to eat the amazing food, and then tell everybody I gave a Ziploc bag of hypertensive medications, right? And so I think that one of the things that's really important about understanding the difference in NGO, and if you are involved with an NGO, you have to understand, like, why are you there? Like, are you there because you want a career in global health and like, do you want to retire doing this? Or are you there because you're trying to get that community going, give them what they don't have, like Marc was saying, so that they can sustain themselves and do it? They don't need us, right? Like, Haitians don't need international folks. They know what they need. They know what they have to do. They just don't have the resources because of history, and I'm not going to go into all of that, but because of the history and the way that the international community has treated the country. Read that amazing New York Times piece that came out this morning about reparations for Haiti. Like, that is important, and understanding why Haiti's in the position that it's in. But these NGOs are not putting Haitians first if they're not actually making a difference. It's not about making Haitians sustainable. It's about a lifestyle that they're enjoying that is at the detriment of the people that they're saying that they're trying to help. So be wary about NGOs and who you're supporting. Why are you there? Are there Haitians on your board? Right? Are there Haitians that are helping you make decisions about the things that you are deciding? Or have you decided as foreigners to impose what you think they need? And create that NGO based on what you think that they need, as opposed to asking the community, what do you need? One of the things that I say is, like, you go into a community and then you start building a well, right? You get all this money and let's go build a well. And you didn't ask anybody. Nobody told you they needed a well, but you're going to go ahead. They need a well. Everybody needs water. We're going to go ahead and build a well. And then because you didn't do your needs assessment, you didn't ask anybody. They could have very easily told you, we have a well. It's just broken. You just need to fix it, right? Like, we just need it to be repaired. But you went and killed yourself to build, a new well that's in a place that nobody's going to go to because there's some historical, cultural something in that area, and nobody's going to go over there, right? And you've wasted resources, right? That's tragic. That's money down the toilet, right? And so that's one of the things about NGOs and what the approach is different. When you're looking at these organizations, are they really putting Haitians first? And the first thing to look at is, what is your board composition and who's in there, and like what Haitian is represented in that? And are they talking to people on the ground? Are the people on the ground, what do they look like? Who lives there? Who did they employ that lives there, right? So that they could actually do the work that needs to be done and get the information that they need. I could go on about this, so I'm going to mute myself.
Okay.
Can I add to what Dr. Eyssallenne said? One
Oh,
thing.
absolutely. Go ahead.
No, there's something that she just triggered and was so true is the question is, are you working for the people? Are you working with the people? And that's a big difference, because I think people come in to save rather than people come in to partner. And so there's a difference there. And I think if you dig into what the funding is, what's the objective of the funding, it's either to, like she said, either get a badge or you're actually either there to make a change. So I think really looking at, is there a true partnership with the local communities, the local, districts in the Ministry of Health, or is it I'm here and this is just us, our group, and we're coming to provide a service, but then that service is not necessarily meeting the felt needs of that particular community. I just wanted to add that part. Thank you, Dr. Eyssallenne.
Very good, very good. And somebody wants to know, quickly, how do we access this discussion when the conversation is over? Our wonderful tech guy, Julio, will be posting that on our YouTube channel. Is that correct, Julio?
This recording is
yes.
on our YouTube channel, and also on the very same, on our website, the same page. You register for this event, there's a button right there that says click this video.
Wonderful. Thank you, Julio. Okay.
I'd like to jump in quickly.
Sure.
And I think it also brings us a little bit to the fourth question, but some of the things that the previous speakers mentioned, one of the things that I saw during my research about communities where aid was active from abroad was it was very, very difficult for them to say no to an intervention. When an intervention was offered, a donation of goods, a group of volunteers, a new program, a well, the answer generally was yes, we need that. And it would even go to the extent that recipients would minimize or hide existing resources because they were afraid that the donors would go somewhere else. So maybe they didn't need the well, but they would accept it in the hopes that the relationship would build, and the next time that folks might bring a generator, right? Because they knew if they say no to the well, the donor would be like, oh, okay, no worries, but that village needs a well, so we're gonna go build it over there. And then the next time their resources are available, the generator, it's gonna go to the people who said yes, right? And so I think when we're looking at how do we support initiatives, as Toni said, who's making decisions, who's on the board? One of the things I always look for is what is the power of refusal among the people that the intervention is going to be happening? Can they say no? Can they refuse and still feel like their partnership will continue to exist? Can they push back? Because otherwise what we have is a lot of yes, a lot of useless interventions, a lot of money wasted. And I mean, this is with good intentions. This isn't even going into dumping, which happens a lot of times. This isn't even going into, kind of profiteering and career building, which we've definitely seen. Like a lot of the groups that I looked at were solid groups. They were thoughtful groups. But one of them in particular told me it took them 10 years of engagement before they felt like the folks in Haiti, this was a US-based group, very inspired by Partners in Health. They felt it took 10 years before folks in Haiti would say, no, we don't think that's a good idea, or no, we don't need that, you shouldn't do that. So that takes a lot of time. And unfortunately, a lot of the interventions in Haiti are fly in, fly out. A lot of people that we see in the NGO sector are at the beginning of the careers or at the end. So they are either fresh with a lot of enthusiasm and new ideas and coming in, but then are not going to engage over the long term, or they're coming into it as folks who are close to retirement, folks whose own health may be starting to waver. So it's a tricky, issue to negotiate, even with good intentions, even with respect, et cetera. That's one thing that I always look for is can folks say no to an intervention without fear of jeopardizing the partnership, and that those no's are very important. Who will close a door? Who will refuse? Who will tell you you're an idiot?
Just to let you know, the article Dr. Eyssallenne mentioned, it's also translated in French and Creole. So I posted the link for you it's a great article. Very good. So let's move on. How about we talk about some of the challenges, current challenges in the healthcare system in Haiti, or even here in the States?
I guess I can talk about that since I've worked in both. I mean, I think that the challenge is resource. It's just, a lot of it is just resource. You know, as Mirebalais was growing and trying to create you know, programs for other residents to have opportunities, I was also working in the hospital in Port-au-Prince, like I said, after the earthquake, with Project MediShare. And one of my issues was I could not staff my departments. I just couldn't staff my departments. Now, remember, after the earthquake, many people died, right? Many people died, many leaders died, many physicians died, like a whole nursing school went down, right? If you remember all of that. So, but the thing is that if you step back away from that, what existed before was still not even enough for the people that were actually there. It wasn't enough. Even before the tragedy. So can you imagine after the tragedy? It was even, you're in below zero territory in terms of resources and human resources and structural resources and all of those things that we're talking about. And I think that you know, what came out of that, like really trying to understand the landscape of medical education in Haiti, really was an education, because it's just, everything's in Port-au-Prince. Like, you can't find anything anywhere else. Everything is in Port-au-Prince. And so, you know, there are like a couple in Cap-Haïtien, you know, and Mirebalais is a unicorn by itself, right? Like, there's nothing else out there where you can, you know, around the country besides Port-au-Prince, Cap-Haïtien, and now Mirebalais, where you can actually get access to education. So imagine if you are a student in Jérémie and you have a dream of being a physician, you have to leave Jérémie to come all the way to Port-au-Prince so that you can get training, or come all the way to Mirebalais, right? That's not convenient, you know, that's not convenient. And so there's a lot of, I would say the opportunities to be trained are not there. The opportunities to get access to care, they're just not there. And all of those are based in resources, right? Like, this is just all coming back to what does Haiti have? The GDP help to help. It's like, there's nothing going into healthcare. Any revenue that they get, the percentage of resources that actually goes toward healthcare from a national level is not, it's not enough. It's just not enough. And so I think that's one part of it. I mean, I think PIH is actually, if I'm not mistaken, you can correct me, Marc, I believe the last time I saw it was the #2 healthcare provider in the country besides the state. Is it #1 now? God. Is it #1? So, I mean, and this is not a state, it's a state partnership, but it's not the state. They needed PIH in order to provide those resources. So if PIH goes away, what happens? Imagine, right? And so there's just not enough. There's just not enough. And then in comparison to the US, that's a whole other conversation, but it's still, the disparities are the same in terms of resources, right? Like, the public institutions are not resourced. Folks that don't have access to insurance don't have resources. Folks that have insurance don't have resources. And it's all steeped, again, in capitalism, colonialism, and racism, all those things that we talked about in the beginning of this conversation.
Thank you for that moving sharing, Toni. I think that as I was reflecting about the similarities of the challenges in the healthcare system between in Haiti and also in the United States, I couldn't help but to think about the current neighborhood where I live here in Washington, D.C. is considered one of the most dangerous and also under-resourced, and also a food desert. Talking about lack of resources, there's no hospital in this area. They're currently planning to build one. And I used to live in Cité Soleil in Haiti. I may have shared that with some people in the call. And Cité Soleil is also considered, or was considered, to be very dangerous when I was there. But the other day, after the amount of gunshots that I've heard in this neighborhood and the killings that have happened during the year that I have lived here, that has made me really, rethink about what it means to be considered the most dangerous and unsafe place in the country, and the similarities or even the worsening situation here in Washington, D.C., in the neighborhood that is 10 minutes from the White House. And I think of how does that, how that translates to health, how that translates to opportunities, and also how the media portrays what may be considered under-resourced, and highlight what happens outside of the United States. And when I think about the health system here in the United States, I think about the high cost for payments, and the fact that even people who are working may still not be able to afford the type of care that they need in case of emergencies. And for even me, I think sometimes I'm hesitant to go to the healthcare system because I'm thinking it's gonna be costing an arm and a leg. So we talk about resources, but I also think about access. How do the challenges that exist here also apply, I'm sure, in Haiti when you think about access, and how people are getting to those places, transportation, the cost for transportation, time to take away from the work that people need to engage in to feed their family, how that also prevent people from going to care, stigma. When you think about HIV specifically, how the stigma play a role both in the healthcare system, but also in the community. And I think the work that Paul Farmer has done in Haiti has definitely improved the way people living with HIV is treated. And I think there's one question in the chat about what the lessons learned in Haiti that could be applied in the US is definitely related to HIV. I think there's a lot more work, particularly related to HIV, that can be done to reduce stigma within the communities. Having community health workers providing treatment to people who are living with HIV in their household or in a safe space that is, that is convenient for those individuals. And there's one story I also thought about was in Tanzania, specifically where I have worked, there's a model of service delivery similar to what has been done in Haiti, where people are giving HIV treatment at the community setting as opposed to coming to the hospital. I recently tried to apply for a grant to do a similar project here in Washington, D.C., and the amount of barriers that I was told that we would face to do such project here in DC started to make me think about the potential to translate these evidence, but also the barriers that also exist in the system where the policies, the legal system, and the insurance schemes that people need to go through in order to receive HIV services, particularly PrEP. So this is not for treatment, but prevention of HIV. There's a pill that people can take to prevent them from getting HIV that has been around for at least a decade now, but the barriers that exist remind me of the history of HIV treatment itself. So the access is the main issue because the pill exists, but how do we get it into the communities that can benefit and also provide the social support that is needed, that if people are being given these pills, then how do we make sure that they are receiving, the support needed to keep taking the pills and the kind of, I think to address the barriers that culturally also would prevent people from being interested. And I think that's also going back to the work that Farmer has done, is really understanding the culture of where you work and how that can interface with the services that you want to provide, but also making sure that they can work together. And I think that is there's a lot of room to grow in the US system, because there's a lot of focus on providing the services, but then the culture that is preventing people from accessing them is also a big factor here in the United States. When you also think about the variety, the number of different cultures that exist in the United States. In Haiti is, Haitian culture, but so many cultures exist here that can interface and prevent people from accessing care. And I think we also have to think about the COVID-19 pandemic and what it also showed that continues to exist here in the United States, of course, throughout the globe, but how Black people were affected here. And I think a lot of the advocacy that are needed that have been done in so many different places, considering Haiti, needs to continue to happen here. But I'll stop there.
Wonderful. Anyone else?
Yeah.
Sure.
I just wanted to add a couple of brief things. One is that Dr. Farmer often said that the problems that he saw and the inequalities and such, they were the result of a failure of imagination. And I always think that's such a powerful statement, because a lot of times we do get wrapped up in the technicalities. We get wrapped up in you know, kind of the best, you know, I don't like the term best practices because I think there's no such thing as best practices. There's all kinds of practices, and some of them work well, can change with time, can be better in one place, worse than others. I think we need to look out and be careful of how like managerial logics and how leadership language, which I'm also not a fan of, have infiltrated global health, and what doesn't get talked about. And I think imagination, creativity, resistance, emotion, power are all things that need to remain central to that conversation, but imagination specifically, because I think it is very easy, and especially for those of us who live, you know, I'll be blunt, you know, definitely speaking about myself, like I live on the good side of capitalism. I've got a nice quality of life. I have a high life expectancy in my family. I have the resources that I need in a comfortable home. So, you know, I don't really need to imagine a different world for myself, because like my world's going great, you know. But when you listen to other people's imaginations of what they want, you know, in terms of a safe society, a reforested Haiti, you know, healthcare for everybody, access to fresh water. Again, like it's ridiculous because these are such basic rights, entitlements, and claims. They shouldn't take so much imagination. And unfortunately, like we know to imagine, you know, a thriving and healthy political culture in Haiti today takes a lot of imagination. And I think a lot of people have kind of given up on that and saying it's not possible. But I think that's where our biggest efforts need to take place, is to imagine something else. And then I think we also need to find a balance in terms of lessons that could be applied to the US, or you know, kind of challenges facing healthcare in Haiti and the US today. I think we need to find a balance when we're thinking about, all right, how do we support, what do we do? Number one is to find good initiatives that already exist. And I think in the case of Haiti, that's something that really needs to be done more, because, you know, especially speaking on behalf of foreigners in Haiti, everybody wants to start a new NGO. Everybody wants a new program. People are much less interested in funding or supporting something that's already there. It's less glamorous. You get less attention. You don't get your picture in the newspaper. You don't get your photo on a tap. Toni has a great story about this, about somebody who decided that he wanted a portrait of himself on a bois fouillé, you know, camionnette in Carrefour. But how do we support things that already exist? Number one, good work that's already there, where we can support in ways that they are empowered to speak out to us. And that's recognizing, you know, others' capacities, other resources. That also can, you know, because a lot of people doing the best work are pretty quiet about it. So you have to find them. They're not tooting their horn. They're not doing all the promotion. Like a lot of the groups who are making the most noise aren't necessarily the ones that are doing, you know, the best work. So that's one thing. But then I also think, and this is a danger kind of with models that we have like Dr. Farmer, is we cannot outsource our engagement to people by calling them saints and heroes. And whenever we think about Dr. Farmer or like these amazing figures, and start to describe them in ways that, oh, well, we're not like them, or they were a genius, or, oh, he had something like different or whatever, that absolves us of what kind of engagement we can have. you know, and I've been guilty of this all the time, you know, like I've always said, oh, thank God someone like Rosemary's out there doing something in Boring. I'm like, what about me in Boring? Like, this was the first community that hosted me in Haiti. Like, I can't just be grateful for Rosemary or say, oh, well, she's doing the work, so, you know, I'll write her organization a check and be done with it, you know, or, oh, well, you know, Rosemary's special, or Dr. Farmer was special. He was a hero. He was a saint, you know. I think we have to be very careful about falling into that trap, because that is not community engagement. That is not a widespread involvement. That is not something on individuals. Now, like, I'm never going to become a professor at Harvard. I'm not going to become a physician. I'm not going to be able to, you know, have access, but I don't need to do those things to have impacts in different ways. You know, a lot of people will say, Pierre, I mean, you've got a huge platform. You're a university professor. You see hundreds of students every year. What are you going to do about that? What am I going to do about just the fact that I can afford, you know, a plane ticket to Haiti and some time when I'm down there, either to do some teaching or to do some fundraising or whatever, like within my means possible, there's something I can do. So again, supporting people who are doing things that we admire, yes, finding heroic figures to a certain level, but not abdicating because we think that the heroes are able to do something that we can't, you know.
And if I may share a little bit more, I think some of the things that we do, and I thank you so much for what the other panels have shared, is we have to challenge funding streams. I think it's not enough just to be beneficiaries. And that's one thing that we have overall. It's a big part of our organization is about advocacy. Yes, we do get funding, but, and when you're saying no, it's no, but how can you make a better funder, better donation to foundation? And that's a big part. It's a huge lift. And I think a lot of the times when you are attempting to do projects, or not projects, sorry, when you're attempting to put systems in place, because of the funding, your hand is tied. You have to go through either a sub-awardee or sub-awardee. And by the time that, because we are PIH, but we also have Zami La Santé, which is a sister organization to Partners in Health in Haiti, which is its own NGO. But then in order for, in getting some funds, by the time it gets to you, the amount that you're able to do with the funds you receive, and then the red tape tied to it, it's almost difficult to do the impact that you have. We will do what we need to do, but I think we need to challenge funding streams. I want to go back a little bit more recently to what's happened with the earthquake that happened in August. And even before that, sorry, let's talk about COVID-19 and also the vaccination that came out. One of the key things, and we did advocate a lot on a lot of fronts, but one of the things that when Haiti received some funding for the vaccination, what it went to is what the usually recognized partners, right? However, the usually recognized partners did not engage with the community. In that, what the community members or the community leadership, where you're talking about the departmental directors, the community health workers, the people that are working within the community, the agent de santé and so forth, what they did not receive, what was given was saying we did communication and it was given to one particular group or so forth, but the communication was not widespread. It did not use the same methods that the people within the community saying, this is how you reach the people within a community. You can't print flyers for people in a rural zone that some are illiterate. That is not going to reach the community. There's multiple ways. And so the funding went to one source, but it was not really planned out. And when we talked about community engagement, we're talking about partnership. Post-earthquake, I could tell you one of the questions we kept on asking, and we went in, we are not a disaster organization, but we are a Haitian organization. When one of our people suffer, we all suffer. So we jump in. And in jumping in, when we went through to the South to assist to the areas in the South, and we were part of some of the conversation. And before we did any intervention, I would say one is we sat with the departmental directors. We went over there and said, what is it that you need? Not what we think you need, not what we're going to put a stake in the ground, but what is it that you need and how do we support you? At the other end, when we're in some of the cluster organ groups that we were saying, we're hearing and then also with other funders, we're hearing that we're unable to get the increase in vaccination and so forth that we're having. I'm just using that for example. However, we went back to them and say, these are the reasons that you're having, we're not able to get the successes because we're not actually engaging the community in order to do what we need to do. And this is, I'm going to even go back a little further. during COVID with oxygen. Same thing with oxygen system when we had to put, and I can't talk too much, but in looking at the oxygen layout and the recommendation and saying these are the best places to provide support to make sure that we have oxygen supply across the country. However, we went to our known, or what's gone to the known funders, what did the same thing that did before for years, and you still get the same results. Instead of saying these are the key areas to go to put in and really work with the ministry, these are the areas that we need to put in systems to serve the different zones and to actually have a real oxygen ecosystem. I think we have to talk about funding and what was said that you were given. We were given LTVs. We were given LTVs, the portable, help me out, the portable ventilators. The LTVs, portable ventilators. When we're saying at this time, I'm like, well, we actually need is oxygen tanks. We need oxygen. We don't need the portable, because it's difficult to run portable ventilators when you don't have technicians, when you don't have people that are really, a one-day training is not going to help it. I think we need to stop saying, we need to challenge that funding. And we did. We said, like, stop sending the LTVs. They are not helpful. What we need is a better system. What we need is XYZ. And if we're going to actually do an intervention, let's not waste money going towards, I have a certain amount that I have to give you in Haiti, and this is what you need to take. And we're saying this form is not appropriate for Haiti because you don't have technicians, you don't have facility maintenance, biomed in this certain areas. I'm not saying all over that can actually provide what we need, but if we're going to do something like that, you need to put funding available for facility maintenance. Same thing that we received the portable oxygen concentrators, where you put it within a facility, which is great, it sounds good, but when you put in a facility that has poor electricity, which burns out the oxygen concentrator as soon as you plug it in, that's a problem. That doesn't help. So we can't say that we provided support when we actually did not look at the system. So what we are challenging is some funding streams and saying, if we're going to do this, you need to put some funding in, or we need to have funding for infrastructure repair. Because it doesn't matter of sending the materials if the infrastructure is not there, because what we did is just wasted money. We did not build a system. At the same time, if you're going to put money in there, you need to put some money in there to provide so we can build up biomed technicians. We can build up somebody in facilities to maintain that, because if not, within 6 months, which is what happened, these equipments are no longer functioning. And so we just wasted thousands, if not millions of dollars on a solution that was proposed outside of what the needs are and without the involvement of the people that are providing the care. Or if the involvement is there, it's to the minimal part of it. So what we are saying is challenge the funding from the source and say, look at it in a better way. It's hard, it's an uphill battle, but we have to do it. If not, we are still wasting resources.
Wow. You know what? Before we move forward, I really want to share this comment with the panelists. This is what somebody wrote. So many brilliant, inspiring, deeply thought, deeply felt contributions on this panel. And this panel pushes us to be responsible about our engagement to effect change. I want your brain, people, panelists, brilliant. Thank you so much. Thank you so much. But now I do have a question for you. How can healthcare professionals, community leaders, even, marginalized people, what can they do to support your own work in healthcare in Haiti, or in the States, or in the world? I mean, let's say primary care for adults and children. That's one of Dr. Eyssallenne's specialties. Reproductive health. Talk to us. How can we help you?
Yeah, I think I love the way you frame the question, because I think it's important for us to remember that it is not the job of marginalized communities to like solve this problem. It is the job of everyone else to help solve this problem. I think that our job for them is to gain their trust. That's it, and we have to prove ourselves to them. They don't have to prove themselves to us. I think that's what's one of the things that's really important. I think that what we're doing here, what we're doing now is super important in terms of conversation. I think one of the things that I do on a daily basis, you know, it really breaks my heart to not be able to be in Haiti. I used to go, I mean, I was there every 6 weeks at some point. I lived there, and then when I was starting to move, when I moved back to Miami for a little bit, I was there every 6 weeks, every 8 weeks. And it's been 2 years. I haven't been able to go back because of the insecurity and COVID and all of this other stuff. However, I think that it's important to continue to educate yourself about why Haiti's in the situation that it is. Fight against Haiti fatigue. I hate that whole sentence, you know. But that's what you know, there are papers about this, about, you know, Haiti fatigue and donation fatigue, and fight that. Because Haiti's not in the position that it's in because of Haiti. Zero. That is the fault of the international community. And so it's really important to constantly, whenever somebody says, oh, Haiti wasted their resources, stop them right there in their tracks. That's helping. That's actually helping. And you say to them, that's actually not true. Haiti never got a dime of the money that was given during the earthquake, right? And let them know that. Read those resources. There's the big truck that went by is an awesome book that actually follows the money that never went to Haiti. That's a really good book. And so I think it's important to continue to educate yourself. Do not fall into the, oh, Haiti's so destitute and we're never going to be able to make it. Like, don't do that. Don't get out of that mindset. Continue to educate yourself and those around you, so that you can help advocate for there to be real level change, real system change. One of the things that I'm going to put it in the chat for those of you who are interested. I am part of a global campaign against racism, and Haiti has a chapter. And when there was the Haitian migration crisis that happened back in September, we got activated because we were like, oh, no, this is not okay. And we did a whole political education series around why Haiti is in the situation that it's in. I'm gonna just put it in the chat. Hopefully you can find it. And if not, Regina, you can reach out to me and I can see if I can give it to you so you can disseminate it. But it's an entire political education series. The first series was done in Creole, but it was translated into English, where we basically, you know, we give the history. Like, anybody says anything negative about history, just take them back to 1804. Just say that word. Just say 1804, okay? And let them know that it's not anything that Haitians have done themselves to get them into this particular situation, right? Like, that's not what happened. This was an international campaign to keep the first Black nation to get rid of slavery, to keep them down. That's what this was. And that's what Haiti is going through. And have that passion, have that conversation, talk to folks about the fact that, you know, there should be no such thing as fatigue when it comes to Haiti, because we have all benefited from the tragedies and the difficulties that Haiti has gone through. Right? The fact that we are free in the United States as Black people is because of Haiti. That is a fact. Do you understand? So we are all benefiting from the work and the tragedy and the blood and the sweat and the tears that Haitians have had to endure. And so we owe them. We owe them.
If I could just add to Toni's comments about Haiti fatigue, you know, a lot of the people I hear talk about Haiti fatigue talk about so in the context of post-1986. You know, they talk about Haiti fatigue having to do with the late 80s, certain hopes there, the 90s, 2000s, the earthquakes. And I think, what about Haiti fatigue from the point of view of Haitian people who for hundreds of years have been facing, you know, transatlantic kidnapping and its consequences, basically, of white supremacy. So effectively, like I think most of, and I never hear them talk about Haiti fatigue. I hear them talk about that they hope their country is going to change into something else in terms of its economy, its society, its living circumstances. And I say too, a lot of times that pessimism is a luxury. And that the people that I've met in Haiti who are the most optimistic are the ones who have the most to lose or who have the least resources to keep them afloat. If they give up, it's over for them in 48 hours. And I'm not really exaggerating. You know, they will die of dehydration. So, you know, I think that imagination, that hope, that critique, that productive anger, you know, is something that needs to stay alive. I also am so grateful for Haitian humor because for me, that is a way of coping, of commenting, of seeing outside the box. So that's something that stays for me. We're getting a kind of some messages about the end of our time here. And I want to close with a couple things. One of them I'm a little embarrassed to do, but I'm going to do it anyway because it's HSA and I consider this my academic home. And that is to give a plug for my book, which has a chapter about Paul Farmer and that's being published finally in 2022 after years of preparation. But I describe international aid interventions in Haiti and looking at how Haitian doctors and nurses act as intermediaries in these situations. So this book is really to honor their work, and it's dedicated to Rosemary Cassanho, who was such an important figure in my preparing it. So that's one. And the other is, I think, you know, we're going to hear about Dr. Farmer so much in terms of admiration, in terms of his legacy, in terms of how many lives he changed, how many lives he saved. And I think we never want to lose track of that. I think we also never want to lose track of his critical perspectives. And we saw it over the course of his careers, his early writings versus his later writings. They changed his tone in tone. You know, his first work, his first book, The Uses of Haiti, was so angry and so critical and so kind of driven with the fervor of a young person, in some ways who had nothing to lose in criticizing his government and criticizing history. And then, you know, his later work, Haiti After the Quake, I heard a different voice, and it was still one that I admired and respected, but it was a voice of someone who was carrying the burdens of health systems, who had organizations that were hiring and treating tens and thousands, if not more people, who had to be more careful in how he spoke, who had to be more cautious in what he said, and who spoke with a different voice. And that's okay. I don't think we need to, you know, some people are like, Paul Farmer sold out, or Paul Farmer, you know, became part of the machine. I don't think that's what we need to say or remember. I think we need to say that people over the course of their lives have different responsibilities and different voices, and that's totally normal. We also can't expect one person through the course of his life to keep providing radical critique, especially as his organization changes over time. You know, PIH started off as a little underdog, you know, small organization with few resources, with stolen material from Harvard University, you know, like great. That's not who they are today. Like we said, they're the second biggest provider of healthcare in Haiti. So they are an organization with a big staff, with a large budget and a major impact. And I think one of the ways we can honor Dr. Farmer is also keeping an eye out for critical voices, even if they can be difficult to hear, even if they'll be difficult to read. And two of those voices that I will put out are people who wrote about Dr. Farmer in ways that were more critical. One of them is a young physician who wrote a piece actually called Renouncing Paul Farmer, who started medical school inspired by Paul Farmer, and then became very critical of his project and his work. This young physician, anthropologist, unfortunately passed away very young in an accident. His name was Sam Dubal, and I think he leaves an incredible legacy, even with his piece that many of us will disagree with. But keeping that dialogue is important always. We have to be careful what we do, you know, to people after they pass away. We don't want to freeze them in time or enshrine them. And then another was a really interesting piece from 2002, an anthropologist named Leslie Butt, who had worked on HIV in Papua New Guinea, and wrote a piece where she had a pretty fierce dialogue with people from Partners in Health and people from social medicine at Harvard, very critical about how poor people are represented, how their images are used and voiced, and then pushback from, it's funny because the original text she addressed did not involve Dr. Farmer, But he stepped into the response because he was very angry with this colleague who was writing, critiquing his work and critiquing the approach that they were taking. But I use that dialogue to teach because there are no easy answers. And we have to be careful as well what we do with our heroes and what we do with people we admire. They are human, they are complicated, times change. Again, the movement to decolonize global health, to call into question who has power, who has a seat at the table. It's one that I think is so germane to Haiti, so important in that context. And so keeping these critical discussions alive with affection and with shared goals is something that would honor Dr. Farmer's legacy. That's my hope.
Any final remarks from other panelist members on the legacy of Paul Farmer? Yes.
I would like to just challenge that a little bit. I think there's a difference that we have to look at. I think Paul's legacy is what is us. To an extent, we have to, yes, he was exceptional, and I still think he is exceptional. His words continue to live on. He has faced criticism from the time that he started because it was radical. And there's one thing that I say is sometimes the ridiculous, what people criticize as ridiculous, really later on when they see the changes, they're like, wow, that was a radical move. And I think in the thing is PIH, yes, is global, but we also have to think is PIH is local. It's not a global organization with a global view only. It's an organization that, if you see the legacy, we went into Liberia and Sierra Leone with the idea that it's a health systems issue. It's not going to provide disaster relief, but let's look at the health system and let's partner with the government. And that's those things that we're looking at. And it's also building, or not even identifying, I don't even want to say building, identifying those leaders that have the voice. So Paul was the visible part of it to an extent, but I want to challenge the fact that Paul was only PIH. Paul started PIH. He started a movement that we today continue, because at that table, be very clear, when we're at that table, we are advocating for the patients. We're not invoking Paul's name. We are there because Paul opened a door, and that we are seeing the issues, and with the principles that we have in place in Sierra Leone and Liberia, in Haiti, in Malawi and so forth, and going forth. The whole point is, are we looking and are we working with the government? Because in all these institutes that we're working with, it's Ministry of Health facilities. Because one thing he said is NGOs come and go. The ministry will always be there. If we are there supporting the ministry to do the work and change the systems, then we've actually did something. And I would challenge, I think one of the things is how, and you asked a question too, is how can the world, how can others help? And I love the fact, I think Dr. Eyssallenne, when you mentioned Haiti fatigue, it's tired to say that. To an effect is Haiti, if we really want to help, let's really look at the funding streams. Let's look at what's actually being put into Haiti. Let's actually look at who is working to change things within Haiti, looking at the systems. I'm not looking at the big, promotional things, but actually dig deep and see, is there a system, is there a system change? And are we having local Haitian organizations benefit from those funding to make those changes within that system? Or are we looking at, and these are things that I'm saying is, and also, and I want to challenge that, the Haiti fatigue, but look at also the Haiti progress despite what's happening within Haiti. Because I don't want to just tote PIH work, but with our multiple partners that we're working together that is pushing forward in education, even though we have this political crisis that has been prolonged for so long, I think we have to look at those organizations that are making those great strides that you don't hear so much about, the changes that are happening. And also the thing is, I don't want to just talk about organizations. I am impressed, and I have to go back even with the Ministry of Health, with the departmental directors, but saying, it's almost like they're shouting, this is what we need. But when NGOs, when you said we also have to accept what comes when they partner, like, are we hearing their voices and are we seeing how they're pushing with the small resources they have to make the gains that they have? It might not be this splashy thing, but I think what we as, and I'm going to put myself outside as an outsider in the global health community, is not just look at the major organization, but tunnel deep, get to the root of changes and see the progress that is happening and that continue to happen, that continue to inspire people to stay even in the midst of this fear. And I don't even want to call it Haitian fatigue on the Haitian part. There's a fear, but there's also a determination that we're going to do something, because you have a personal fear of your life. We have a trauma that we're not talking about that's there. You are traumatized every time you try to go to work or you get out, because you don't know if you're coming back in. And even if you get back to your home, you don't know if it's coming to your house. I can tell you of our staff, our team members that have been kidnapped or exposed to that. But even with that, the decision to stay and the decision to effectuate change, I think that's where we need to raise those voices, highlight those, because I think what's promoted a lot of time and what we see is organizations, but we don't see the people making those changes. So yes, Haitians are strong. We are moving forward. We are making the changes. And even though we are tied to an organization, my name is not the organization. My name is Marc Julmisse. I am part of this organization, and I decide to stay because of what we see and because of the gains that we're getting. So I think we need to see the people moving forward. And that's one thing that I would challenge is don't get tired and look at the whole, but drill down and see the individual.
Wonderful. Wow. It looks like we have, it's 6 o'clock. We have time for one question, just one last one. Make it short or a comment. I did see Lane Shelby raised her hand. Make it quick, comment or a question for.
No, I just give thumbs up and I clap.
Oh, okay. Okay. Anyone else? Okay. Yes.
I just would like to put a plug in. I'm sure all of us know this already, and just would like to remind us to support by making a donation, because the work requires a lot of support that is happening in Haiti or elsewhere where PIH works. So just reminding the attendees, if they haven't supported, PIH by making a donation, that they can. And I say this because I've been interning with PIH for a decade now, but I remember when I received, I never thought about making a donation. It was not automatic for me until I received something in the mail that said, oh, you should make a donation. So if you haven't, please, I strongly encourage you to do so. So that's the last comment I had.
Lucien?
Yes.
I'll be very brief. Paul was a friend, and I also want to express, HSA's condolences to the family and to all of you who have worked so closely with him. He was a friend of, close family member. And I remember the time when he was being encouraged to actually go to medical school when he was an anthropology student at the time. So one thing about Paul is really his kindness and his humility. And I remember being on a panel with him where he really expressed how much Haiti made him. And we honor him, but like, Pierre and all of you have said, we don't want this notion of being a saint, but there are some lessons beyond the health equity about the sacredness of life, the sacredness of the human being that Paul left us. What is our responsibility towards the world? And there I remember his daughter Kathleen at the memorial when she said that he would, her father told her that he would do it again if he had to do it. And she ended by saying she would also share her father with the world if she had to do it again, despite the sacrifices of the family. There's a professor at UC San Francisco, Shrimwan Shamasnunder, who was with Paul until the week before he passed, and exchanged notes with him about this patient in Sierra Leone who had AIDS, and Paul delayed his trip in Butaro so that he could deal with this patient. And the patient died, that Saturday, I believe. And Professor Shamasundar sent this poem of Mary Oliver to Paul. And Mary was a friend of Paul, and he said he had not read the poem in a long time. So we should know that Paul read that poem 2 days before he passed. And let me read you what it says, because the lessons are there for all of us. You must be able to do 3 things: to love what is mortal, to hold it against your bones, knowing your own life depends on it, and when the time comes, to let it go. So the writers there said that, we must let go of Paul's physically, but of his physical life, but we, and all his students throughout the world and all the patient will never let go of the examples that he left for us. So we honor Paul. May he have a safe journey. And thank you on behalf of the people of Haiti and of all those that he helped in terms of health equity throughout the world.
Thank you so much.
Use.
Thank you so much, Claudine. Once again, we want to thank our panelists, Dr. Conserve, Dr. Minn, Dr. Eyssallenne, Ms. Julmisse. Thank you so much for your thoughtful reflections on Paul Farmer's ideas, work, and legacy in your own work. Really appreciate your own work in the States and Haiti, and your care, your compassion for global health equity. We also want to thank the wonderful people in the audience for your time. Thank you for spending 2 hours with us. Let's, Miss President, would like to make some announcements quickly.
No, I think we are ending on the exact right note tonight. But Claudine, thank you for that. Everyone who shared their thoughts, their work, their thoughtful, loving, radical critiques of the state of the world that we find ourselves in. I just want to say thanks again. I put my announcements in the chat about our upcoming events. We will have events every month this summer. We will convene, fingers crossed, in Washington, D.C. in October for our 34th annual conference on the theme of Maounage and Haitian studies. And so we just want everyone to join us for those events as well. Thank you, everyone who gave their time tonight. We will keep the space open. There are lots of comments in the chat, words of appreciation. We won't end the meeting right away if anyone wants to unmute their mic, but we thank you for your time and your attention.
Also, the links to this talk is posted in the chat room. So share it with friends in your circle.